We also make a very good use of muscle relaxation, making sure that the patient is fully relaxed in case the relaxation is wearing off. And also adequate light, making sure the light is shining adequately into the wound. Ideally, the light should be multidirectional and focused. And one of the tricks that is quite good to use is sometimes very difficult to know where the light is focusing on the abdomen. But if you just open a gauze and lay it where you want the light to be focused, somehow the white gauze highlights the focused light much better than the abdomen, the skin. So that's just a trick that I use. As I said, you always palpate the abdomen, and you put, you would have palpated the abdomen anyway, and you would make the incision just over or just above any mass palpable. Once you have reached the extraperitoneal fat and that's cleared, then you have the shiny peritoneum, which is lifted up and held between two clips, and then with a pair of scissors you open it, and sometimes you just immediately get some pus, and that sample of that is sent for the culture and sensitivity, which might become useful for post-operative antibiotics if required. And then the peritoneum is opened. Either you just split it open or you just cut it open, and then a proper retraction. The first thing that you want to do is to kind of clear and suck all the pus out and make an assessment about whether your diagnosis is right or not. For example, is it pus, is it blood, is it bile stained fluid? You might be in a completely wrong quadrant, chasing an appendix, when the problem, for example, is a perf DU. The first thing you would want to do is just very gently and carefully suck any fluids out. And most of the fluid will be in the pelvis. And the way you do that is you get a retractor, give it to your assistant, and lift the lower edge of the wound up, and gently you introduce your suction device into the pelvis without forcing it, and that's very critical. It just needs to slide down, and one of the things that you can do is, while you're sliding it down, you basically bend the tubing of the suction so that there's no suctioning happening. And then once you're down, and then you just open it, and then you get all the suctioning out. And then before you pull it out, again, stop the suctioning fully, and then just shake it a little bit and then pull it back. And you might want to do the similar thing up the way, especially in the right paracolic gutter. The next thing you want to do is you want to identify the appendix. And in my experience, palpation is superior to visualization, particularly in an inflamed, and certainly in the case of a necrotic appendix with an appendix mass around it. And with experience, you very quickly feel this. And the way you would do that is, with the wounds retracted nicely, you would basically, with your left hand, grab the cecum and gently pull it out of the wound, with your right index finger going behind and feeling for the mass or the lump, which is going to be consistent with the appendix. And very often it's either sitting in the right iliac fossa, or if you're a little bit unlucky, stuck to the posterior wall of the cecum, so-called retrocecal appendix. If you can't feel it, and then you're really into kind of perhaps very carefully looking for the teeny eye of the cecum and following it, and that should in theory lead you to the base of the appendix. If the appendix is not adhered to anything, then you basically just going to grab it with aid of a swab and gently pull it out with the cecum out. You might have to mobilize the cecum slightly laterally. It's very often not required, hardly ever. The main use for the cecal mobilization proper is if you're ready to going to do a cecectomy or a limited rhemicolectomy. The appendix is usually just teased off and eased off the posterior wall of the cecum or the surrounding structures with just gentle blunt dissection. There might be a little bit of ooze or bleeding, but if you do it gently and with experience, you just find the right planes and you mobilize the appendix out. Occasionally you might have to do a bit of a pinching to mobilize the appendix out, and once the appendix is separated, then sometimes the appendix is all contracted and deep into the wound, and the trick often is to isolate that with the aid of maybe a few swabs carefully strategically placed around the appendix, and with your assistant using the appropriate retraction, and kind of that isolates the appendix from the wound, because sometimes it's very difficult to mobilize it out of the wound. It's not really necessary if you've got a good view of the full length of the appendix. Then you need to make a decision. Is the mesoappendix, obviously you need to take the mesoappendix. If the mesoappendix is thickened, you're going to really have to clip and not tie but transfix. That would be my advice. Use 2-0 PDS and 2-0 Vicryl and transfix either all in one go or sometimes maybe 2 or 3 chunks. And you basically, that way you're really making sure that your clips, your tie is not going to slip and you're not going to get a hematoma postoperatively. If it's quite thin and flimsy, then you might just decide to just tie it. Once that is tied and the appendix is fully mobile, then the critical thing is to make sure that this is indeed the base of the appendix. At least on one occasion, I've taken a patient back to theatre who'd had a previous appendicectomy a couple of years earlier, and it was a stump appendicitis, and you could actually see quite a long segment of the appendix which was inflamed and with the other bit missing from the previous appendicectomy. So it is not that difficult if you're not careful to leave quite a long length of the appendix, and that's the risk that you take. So it needs to come down to the cecum and with a teeny eye coming up, and you basically clip just at the junction between the cecum and the appendix, maybe about ½ centimeter above, and then you put your tie at the junction between the cecum and appendix. A square knot, we all know how to do square knots without doing granny knots or slip knots. And then you take your scalpel and you cut the appendix off the base with the aid of with a scalpel just under the clip, and you just take it off. Then you've got the option of either burying the stump or just leaving it alone. I think if the cecum looks thin, nice, not thickened, you might decide just to put a purse string with 2 Vicryl, lubricated Vicryl, and then pushing it down and then tightening it, and that way you're making sure that there's no possible adhesions that some people talk about if you leave it might form, but it's completely okay to leave it. In most laparoscopic appendicectomies nowadays, people don't bury it anyway. Traditionally, we used to use a bit of betadine to kind of just dab the base left, or some people even use diathermy to burn the mucosa. And then at this point, you've completed the procedure. Now, there are 1 or 2 problems. One is, what if you've seen pus? Appendix looks a wee bit injected, but not too bad. So one of the things that some surgeons can get caught out is what I will call a secondary inflammation of the appendix and appearance of the inflammation because of the pathologies elsewhere, and the appendix appears to be inflamed. For example, rarely like Meckel's diverticulum. Some people argue you should always extract maybe 2 feet of the distal ileum just to inspect for possible presence of Meckel's. If it's present, leave it alone. If it's inflamed, you might have to resect it. But just be aware of it. That appendix, if it doesn't look too bad and the pathology on the CT scan showed gross contamination, or you see a lot of pus, start questioning your findings. Don't just assume that it's appendicitis. Washout is probably the most important part of the whole procedure. Now, access again, it's not great for all four quadrants, so I wouldn't advise you to pour in jugs of water into the abdomen, because all you then do is you end up with loads of saline, which is not going to be possible to wash it, to suck it in the other quadrants, particularly in the left upper quadrant above the spleen, and that can form a subphrenic abscess. So I would use a 60 ml bladder syringe, sterile one, and you basically target the pelvis in 60 ml increments, and then you just suck, and then you again another 60, and then suck till it looks clear, and you do a very similar thing by retracting the wound up the way towards the liver, and you do a similar thing here. Sometimes do patient in the reverse Trendelenburg position slightly. That helps the saline that you're using to come down rather than staying up above the liver. And that's one of the limitations of open right iliac fossa incision for open appendicectomy, is that you never get a good view for a full washout, and this is why you might consider doing an midline laparotomy if there's gross contamination. The other question that people have asked me is whether we need to put an abdominal drain. By and large, the answer is no. But if you do have, say, a very kind of mature, thick-walled pelvic abscess that you've drained, probably that's one situation that I would advise you to put a drain into this, because otherwise it would just recollect. The abscess wall will just keep producing pus for a while till it collapses. So I would put a drain into that, a single drain, and it doesn't stay long, and it can come out as soon as it looks clear. And perhaps in that situation you might consider continuing the patient on antibiotics. What are the other problems is when it comes to the closure of the abdomen. Make sure that obviously you haven't left any swabs inside. Your count needs to be correct. And the closure starts perhaps with the peritoneum. The advantage of closing the peritoneum, if you can, is that it keeps the bowel down. It doesn't really have any strength, and I mean, we don't do that in laparotomy, but in this case you might consider doing it separately if you can, with just a tuovitral, just a running one. That's a neat way of just keeping the bowel down. And also be aware that if the patient's muscle relaxation is wearing off, that you don't injure the bowel, particularly that would be a real risk here. But I would do this in two layers. One is the transversus and internal oblique. I would close them with probably interrupted, taking the epimysium in particular, because that's the strength of it. But that's not the strength of the closure. That's just opposing it. And critically, the muscles need to be just opposed, but not squashed and strangled. It needs to be pretty loosely done. It almost looks too loose. And that's a good closure. If you strangle it, it will cut through, it becomes ischemic, and it will get infected. And it's interrupted because it allows infection to find its way out if there is an infection. And I will do the similar thing interrupted for the external oblique aponeurosis. And then for skin, if it's gross contamination, you might even want to leave it open for 48 hours, put your stitches in, interrupted, that you can close it on the ward with a bit of local anesthetic, just tying them. But if you if that's not a worry, then you just close it with interrupted suture, such as Proline. And interrupted, I feel, is better, because then it's easier to remove these stitches as required to let the pus out. Occasionally you might decide even put a corrugated drain into the wound, and that kind of keeps it a bit dry. Well, I hope this online tutorial has been useful, and hope to see you soon. Thank you.